I feel like every meeting arrives at a tipping point, and the tipping point is when you realize that you're about to say things that everybody has said already. But that happens in every meeting, so I hope I'm not repeating some things, but I hope I'll be providing a little bit of a different emphasis. So I was given the task of speaking about prioritization of populations. And I want to start by saying that whether implicitly or explicitly, there is a need to prioritize populations, whether implicitly or explicitly. So let's go through the talk. First of all, you all know about ART for prevention, and we have the evidence confirmed through 052 in terms of the efficacy of this intervention. But we need to go from this to this, is really to demonstrate the effectiveness and to really be able to shut down new infections globally, particularly in Southern Africa, where there's the highest incidence at this point in the general population. So I'm going to start by the three things I want to end with, because I'm not sure I'm going to make it through all of my talk. So the first thing is that remember an iceberg, and this means that we should be very careful as we're considering how to reach our goal and the potential of treatment of prevention, not to focus on the iceberg, meaning the people who are already identified to be positive, meaning the people who come to our clinics already, meaning the people who are retained in program. We should be always focusing on what's beneath the surface of the water here, the total iceberg of the total group, the total population of people living with HIV who may not be aware of it. The second issue, of course, to leave you with is the issue of the importance of the HIV continuum, because that's going to be critical if we're going to achieve the potential of ART for prevention. And as I always remind myself, is that it's not just the testing, the engaging in pre-ART care, ART care, and then achieving viral suppression, but it's what we have to do to link the individuals between these boxes, and that's very fundamental. And the next principle is that, of course, is that we can't claim credit by just doing one thing very well if we're not doing all the other things very well. And we've coined this, my colleague Molly McNary has coined this phrase of no partial credit given, meaning that in order to achieve the potential of ART for prevention, we have to do very well at each of these steps. And lastly, I think something else is to keep in mind is that all of these interventions and programs need to be accessible, need to be acceptable by the populations, need to be of high quality. We need to achieve coverage and in order to achieve effectiveness at a population level. So here I've summarized to you everything that I wanted to say, so let me tell you a little bit more, okay? So let's get to the iceberg. I think people have mentioned already the worrisome fact about those who are unaware of HIV infection, and these are data from KAIS in Kenya just last year, 2 years ago actually, that looked at among those who were HIV infected and found that about half of them reported they were HIV positive. 37 of them reported they were, of those who were unaware of infection, 53% were unaware of their HIV infection of those who were HIV positive, and you can see the breakdown here by those who were tested, known to have tested before or not. So we have a long way to go. Another challenge I feel is that the issue of trying to reach people at earlier stages of HIV, and people have commented on this before, and these are data from several countries, 44 studies looking at the mean CD4 cell count and enrollment in HIV care, and that's the more important parameter. We tend to look at those who initiated ART, but that's not really relevant. What's relevant is what does those who are engaged, enrolled in care, and thus might be potentially eligible for ART. And you can see here the change over time is there's been a slow increase, but still this is enrollment in care, not initiation of ART, that's about 300 CD4 cell count. We've noticed these are ICAP data from ICAP-supported programs from several countries in sub-Saharan Africa, and you can see over time there's good news. The median CD4 at enrollment in care has been increasing. This is in care, and the proportion who are enrolling with advanced HIV has been decreasing. So there's evidence that those enrolled in care are coming in a tad earlier, although still with quite low CD4 cell count. Then let's talk about the populations we want to treat. Obviously, the most dramatic benefit from ART has been observed with those with advanced HIV disease. You can see here with lower CD4 cell count. You can see here the rates of events, death, AIDS, or severe non-AIDS event is much higher in those with lower CD4 cell count than those with higher CD4 cell counts. And we also know, luckily, that it's in the same group, those with lower CD4 cell count in discordant couples, that have been shown to be that have the highest risk of transmitting to others. These are data from discordant couples. So at low CD4 cell count, in untreated population, the risk of transmission is much higher. So it means that somehow, if we want to get the bang for the buck for ART for treatment, certainly making sure we treat those with late disease is very, very important, both for their own health as well as for prevention purposes. The challenge is, of course, about those who are earlier HIV disease, where the event rates are much smaller, and therefore the benefit of ART is going to be much harder to demonstrate. And these are the data from 052 on individual benefit in those who are HIV infected of early ART versus delayed ART. And as you can see here, there was a trend in a benefit, but nonetheless, overall, it crossed 1. The confidence interval crossed 1 for the overall population, as well as for these subsets of the populations. Even though the estimate is here towards favoring early treatment, nonetheless, it crossed the confidence interval. So I think the more we can get data to confirm individual benefit, I think it will help very much in us trying to sell early ART for prevention. These are the same data. I don't have time to get into them, but it provides the same finding. One of the challenges has been that has been raised, and it's very encouraging, the data from Diane regarding willingness to initiate ART. These are data from South Africa, large numbers of HIV-infected individuals. And what was interesting is that about 20% of the individuals found to be HIV positive refused referral to initiate ART. And those who refused had very low CD4 cell count. And the most common reason for refusal was feeling well. So we have to deal with this issue and to change the norm, as was discussed earlier today, and to figure out how we can change the norms and how to also provide the right messaging. And this is the title of one paper, actually, which is very alarming. If I'm given ART, I will think I'm nearing the grave. This is from someone from Kenya in a study. And it demonstrates to me that I think it's really important to take such statements very seriously and try to transform the conversation about HIV and when to treat HIV disease. Now, these are data regarding, okay, if we want to expand ART, and these are data from Swaziland and from a study done by the Ministry of Health. Velepi has talked about the work in Swaziland. But what's interesting, if you look at the data, it's a random sample of the population. And of those who are not on ART, who are HIV positive in the population, you can see the distribution of CD4 cell count. 43% of them had high CD4 above 500, and 25% between 350 and 500. And these were the lower CD4 strata as per current ART guidelines. So essentially, with expansion of treatment, this is what it looks like in a country like Swaziland at a population level in terms of trying to reach, I guess, this segment here and this segment here, if we're going to be trying to reach all of those who are HIV positive with early disease. Now, going back to the continuum, I think a very important issue is when we talk about ART for prevention, we tend to think of going out and finding new people who are HIV infected, early disease, and bringing them in and initiating ART, or going out to them and initiate ART. We forget the people that are within our midst who are either in pre-ART, who can be initiated on treatment if they're eligible, and most importantly, to retain them and to start them, as well as to make sure those who are on ART remain on ART. And this is the issue, of course, of the quality of the program and dealing with the leaky cascade, as Velepi mentioned. Very, very profound importance, whether we're treating people with late disease or people with early disease. If we're not doing well in this, we have a problem. This is a care continuum. These are data also from ICAP-supported work, also by Mali, presented at CROI. These are from 4 countries, large numbers of patients, 390,000 patients enrolled in HIV care. You can see that about 89% had an assessment for ART eligibility. About half of them were ART eligible, 70% initiated ART, and 78% were retained at ART at 12 months. So this is what the cascade looks like when you use a surrogate, which is ART retention at 12 months, because in most countries in sub-Saharan Africa, viral load is not available. So again, it shows the challenges we have, and in terms of the numbers as well, if we are really to provide earlier ART and to try to engage all of those that now are not eligible essentially, but are in pre-ART. Now, there are risk factors for loss to follow-up, and these are data that I think are instructive. These are data from Rwanda, from ICAP-supported program there, and of 31,000 patients in pre-ART care. And lo and behold, guess who's more at risk for loss to follow-up in pre-ART care? Men are. So not only is it more difficult to find them, but if you find them, they're more difficult to retain in pre-ART. And you can see that as well, there's a gradient. Those with the lowest CD4 cell count are easier, better retained than those with the higher CD4 cell count to be retained in pre-ART care. And when you look at those on ART, again from the Rwanda program, 17,000 patients, again, those on ART, men are more likely to be lost to follow-up. And you can see here also the single more likely than married to be lost to follow-up. And even then there's a gradient, even under 350, there's a gradient also in terms of retention in care in ART. There are data, as you know, that show that retention HIV care by initial CD4 cell count is also follows the CD4 gradient with better retention at 200 at lower retention at the higher CD4 cell count, again challenging us to think about how to do better with this population. What about key populations? I was asked to focus on populations. I think we are very concerned, obviously, in lower middle income countries about populations in general, but key populations are very important. And I want to focus on MSM. Very high prevalence, again, median prevalence of HIV among MSM as high as 19%, West Central Africa, 15%, Eastern and Southern Africa, and this is compared to lower prevalence in other parts of the world. What's worrisome to me is, of course, MSM have much more limited access to all interventions for prevention and also for care and treatment. Similarly for commercial sex workers, and again, look at the prevalence in these regions in Africa. What's even more important than prevalence is what's the contribution in terms of this population to the number of new infections. And I think there's evidence evolving that both MSM and commercial sex workers contribute substantially to numbers of new infections in countries in sub-Saharan Africa, and that's what's critical about thinking about these populations when we're thinking about ART for prevention. We have to include them if they're contributing substantially to the numbers of new infections. Then another thought I had is obviously when you think about focusing on populations, even in a country with a generalized epidemic, these are data from Lesotho, another place where we work. And quickly, for those of you who don't know Lesotho, it's not that far from here. A small population, very high HIV prevalence, with large numbers of HIV-infected individuals. But nonetheless, there is a variation in HIV prevalence within the country, and we're talking about prioritization of populations. This is very mountainous countries and very hard. The roads are not great, and you can't reach some areas of the country. But as you're looking here as HIV, this is work we did a couple of years ago. You look at the prevalence amongst males, prevalence against females, you realize there's variation across the country, although all of them are pretty high. And even we have data from one district, from Basero district in Lesotho, you can actually map where the highest prevalence is within one district. So I think now we have the tools, I believe, available to all of us using these. This is actually using VHS data, but we have some data that are available that can be utilized in order to think more carefully about, if we have limited resources, how do we prioritize populations, even in the context of a generalized epidemic. So in conclusions, I think achieving the promise of ART for prevention requires attention to certain issues. Those who are unaware of their status, those with higher CD4 cell count, men, very important. Continuum of care for those in pre-ART as well as on ART, key populations that contribute to new infections, the quality and coverage of the program, and I think very importantly, the need to innovate. And by innovation, I mean those kinds of implementation science types of studies that try to experiment and actually compare in a rigorous manner different ways of implementing various components of work. I think prioritization or lack of prioritization of populations will occur either implicitly or explicitly. I think it's the reality, and we can't say that we're just going to treat everybody. It doesn't work that way. We have to think carefully what we mean when we say that. Otherwise, there'll be implicit prioritization. It might be in the wrong direction. We need to use the data to inform the way forward. And I do believe that information will be derived from the results of the large clinical trials that are ongoing. These are the information that's going to guide all of us in the future, as well as from implementation research. And we're also going to be informed by programmatic realities and, of course, available resources. Thank you very much.